Okay, well, let's make a gentle start. So, hi everyone. I'm sure I know many of you. My name's Mel Hingarani. I'm a consultant ophthalmologist at Moorfields. I'm chair of the UKOA, and I'm also one of the clinical leads for the National Eye Care Programme. So we thought that what we try out is some shorter meetings, kind of lunchtime focused things to try and change the access, try and get perhaps a few more frequent meetings, and ideally do a bit more about selecting some units who can really share their practice and share what they've been doing and how they've been responding to many difficulties that we've all been facing recently. Have the next slide, please. So just to let everybody know, we're recording the meeting. We've already started recording, as we always do for UKOA meetings. We put them on the members section so people can access afterwards. If everyone could keep muted unless they're speaking, that'd be fantastic. Raise hands electronically to ask questions, and also please do use the chat function just for ideas, questions, exchanges. Just to, a lot of the value of these meetings is really sort of asking the questions and having the discussions about what we're all doing. So please do use that actively throughout, and I'll try and keep an eye on that. And as those of you who've been before will know, if things are being a bit quiet, and or I think that somebody on the audience, I think will have something really useful to add. I do occasionally sort of pick on you out of the blue and ask you to sort of chip in, so please don't take offence and on that, if that's okay. Can we have the next slide, please? So I'm just going to have the next slide. I'm just going to give you a bit of an update on the eye care improvement programme, because there's been quite a lot going on, and I'm afraid I'm only going to have time to give you a bit of a flavour if we're going to give our friendly colleagues any chance to speak. So I'll touch on a few bits. So just to let everybody know, because I don't know how much people are aware of this, the eye programme is part of something bigger called the Pathway Improvement Programme, but we have some extra stuff that the other specialties don't, if you like. So the Pathways Improvement Programme, you can see the description above, essentially led by NHS Improvement basically, and the idea of this was to really initially to pick on 2 or 3 specialties who really had big ideas about what are the, we haven't just got problems, we've got solutions, we know what we want to implement, please work with us. And so the 3 chosen were us, eye care, really we use the word rather than ophthalmology, just to really convey that we're talking about, incorporating primary care optometry as well, and then musculoskeletal and orthopedics and cardiac services, which includes both surgery and cardiology. And the idea is that these would look to recover and then transform in a really end-to-end way. You'll also all be so really from the point of primary care all the way through to discharge and whatever needs to go on in the community. In addition to that, the high volume, low complexity stuff led by Getting It Right First Time has sort of come into being, driving the kind of productive theatre pathways for these specialties and a number of other specialties as well, and that is incorporated in as part of the whole thing. Can we have the next slide, please? Now, one of the things that I think's made a big difference to the priority and the seriousness with which both providers and commissioners are taking the whole eye care thing, we've been a bit of a Cinderella specialty in the past, and no matter how well it's been communicated about how important it is and how harmful the delays are, nobody cares until something goes into the NHS England planning letter, which goes out to all systems and regions and carries much more of a must do and requires systems to incorporate these requirements into their planning returns for the year. So as part of the NHS planning letter, there was an annex about the eye care. It doesn't really matter too much about exactly what this says, but people being basically sort of told that these are the things that we expect you to do and to take seriously and have a plan for. And also you need a system, you need a framework. It's no good saying you're going to do something if you don't have leadership and project management. So asking people to set up eye care boards or delivery groups at region and system level, that they have an improvement plan for ophthalmology and they have all the right people, including clinical leadership, and that everybody else, all the other stakeholders are involved. So that's, I think, to me, a really big coup to get that in, and now people are listening. The next slide, please. I think in addition to that, so that was good, and that definitely made people who hadn't taken ophthalmology terribly seriously before sit up and listen. I think the thing that's really hammered home the message is around the waiting times. So this is taken off the sort of NHS England's information. It's the May 21 sort of weights, and this is just Midlands, just picked randomly. The message is, doesn't really matter what the numbers are, the message is that for most areas, ophthalmology is either at the top or in the top 3 in terms of patients waiting, and that includes a hell of a lot of cataracts. And although probably many of us are far more interested in the glaucoma and the medical retina because they go blind, the fact that there are hundreds of thousands of cataract patients waiting, and that this is measured, and you've got all these 52-week waiters, again makes all the people who have the power and the money start to go, oh my goodness, we must do something about ophthalmology. So there's a huge amount of attention and focus everywhere on getting this right. Have the next slide, please. In terms of going back to our programme, so the idea of our programme is that it brings all of the different bits and bobs of eye care together. So we've got the National Outpatient Transformation, getting it right first time, electronic eye referral people, you know, whoever, anyone who's involved in it, high volume, low complexity, we are all working together as one end-to-end eye care coordinated team, we hope. And in terms of what our objectives are for getting things into practice this year, these are the sort of key things, and I don't think any of this will surprise you, but really it's about high volume surgery and making sure that everyone works together so you don't have huge inequity, that you have a massive waiting list here in this provider and a tiny waiting list in that provider, that it's going to be coordinated for equity, that we get more efficient with our clinics and outpatient procedures in hospitals, community settings, incorporating all the videos, the virtuals, really robust discharge, using the whole multidisciplinary team and making sure that patients are better supported, which makes us more efficient in the end. And underpinning all of this with risk management, with consistent tools for risk stratification, fail-safe processes for the high-risk delayed, and recording of those delays via the ECAD field on the patient administration systems. And then doing these kind of standard integrated pet care pathways so that everything's joined up. And I guess of all of the things we need to join up, I guess the key for many people is how we're going to incorporate primary care optometrists into the pathway in a way which works for us, works for patients, and works for is affordable and works for their businesses, which is no small challenge. Next slide, please. In terms of what we've been doing recently, and again, a lot of you may know this or may have been receiving materials depending on what sort of leadership roles you hold. The team has sent out a support offer document to regions and systems, trying to outline exactly what we could do in terms of manpower, skills, expertise, time that could help them do what they need to do locally, and asking for people to sort of get back to us on what they want. We've already launched, but it's not completely finished, but there is a new website. So many of you may have used the eye care hub on the Future NHS thing, and it's a bit of a nightmare. It doesn't work very well. You get lost in dermatology almost instantly. You can never get a login, etc. So we've now got a new dedicated website, which is part of the NHS platform, but is completely separate, so you can't end up getting lost in some other specialty, the eye care hub. And what we've tried to do is really rationalise the materials so that you have much more in the way of how-to guides and sort of more materials to help you just do what you need to do rather than scratch your head thinking about it. And we'll come back to look at that in a minute as to what sort of stuff is on there. Other things that have happened lately, many of you will have seen that the two colleges released a joint statement essentially supporting avoidance of in-hospital care for routine cataracts with no serious comorbidity, which would instantly free up a huge number of referrals. And what they're trying to do is they're taking a business case to NHS England to pay all optometrists a small fee to simply do the site test and return the nod data. And they're also working on some sort of digital solution to get the data back easily. So I'll report back as and when that might get approved. And then we're now spending a lot of time actively engaging with all the commissioners and all the regions to say, okay, we sent out our support offer, who are your people? How would you like to work with us? How can we help you? It's not that we're doing it, the systems and the providers have to do this for themselves, but how can we help support that? We've also been holding some workshops specifically with primary eye care, looking at really trying to crack some of these difficult commissioning and workforce issues so that we can all agree on competences and qualifications and how we fund and contract primary eye care. And we also have, as well as the kind of, if you like, that you really ought to do these things this year, we've also got quite a strong transformation part of the programme. A lot of it's centred around digital transformation. So looking at what are we going to do next year and the year after that and the year after that, and how can we get very clever in terms of, the taking advantage of all the new digital opportunities and interoperability and data flows. And they're working on four key areas and trying to develop things that can then move into practice, hopefully in the next 9 or 12 months. Next slide, please. So this is just one of the slides that's in the support offer package, which the regions and systems have been receiving, about these are the sorts of things we can offer. These are the sorts of the materials that we have. Go on to the next slide, please. And then as part of that, there's like a sort of list of slightly more specifics about areas where we think we can add value or help, or help sort of people do some of the nitty-gritty local work. Next slide, please. So in terms of getting information, so going back to this eye care hub, you should be able to get more or less straight in. You've just got to register. You don't normally need to wait to then get in. Nav can tell me if that's not right, but I'm pretty sure in the old days you had to email someone and wait for a login, but now you just register and you're in. You don't need an NHS email, so that means all the optometrists and anybody else can just get in. Anyone can sort of get in and have a look. So it's much easier to engage with, and then you can see how it's laid out there with various different things. I'll let you all know as soon as it's got the absolute core material, when it's worth really starting to take a look. It's absolutely fine to go on and have a look now, but it's not quite there, and it'd probably be worth waiting about a week until you can get on and really see the decent content. The next slide, please. But just to sort of show you this whole kind of try to sort of simplify stuff, and this was based on a lot of feedback, particularly from the commissioners and from the kind of the hospital provider management and execs. They actually were very keen for it to be a bit more prescriptive than perhaps we've done before. So you've probably seen, things from the college and GERFT about high volume cataract surgery or macular. It's all very wordy. You've kind of got to work quite hard, particularly if you're not an ophthalmologist, to understand what it's saying. So this is much more, we hope, bullet point and focus. So this is the macular degeneration how-to guide. You'll see that we've redone all of the pathways from the outpatient transformation in the GERFT style, and broadly, if you looked at that pathway and read what was in each box, you pretty much know what needs to change to do what you need to do to get this right. Underneath that, you can just about make out key actions, and again, basically you need to do this, and this. This is what makes the difference. And then within the checklist, we've broken down everything. Again, just keep it simple for everyone. Stuff you do pre-hospital, stuff you do in hospital, stuff you do post-hospital. And you can start to click into these and start to find, again, some real stepwise 10 or 20 steps that you just need to go through to tackle the workforce issues within your cataract pathway. And what we've also tried to do is give as much as possible either nationally produced or local exemplars of materials that anybody probably is going to need to do these pathways. So we could perhaps just go on to the next slide. So I'm hoping you can sort of see here. So for instance, people said, well, you're telling us to do this risk stratification of news and follow-ups. We're all separately trying to invent a tool. Please, can you give us something? So at the top, we've put together a sort of generic version for glaucoma and cataract, glaucoma and MR, based on what a lot of places are using, an amalgam, so that all of the teams can go, new patients with this, how do we define high, medium, low risk? What sort of modalities of care? Is that a nurse-led? Is that a virtual? how long beyond the time scale do we think we have to re-stratify because the low risk might have become a medium risk then? So to try and sort of hand people tools that either you can take and use or you can adapt, so that if you haven't got this, you don't have to spend hours and hours working it out for yourself when it's fairly generic. At the bottom, you have an example from the RCOP from Bournemouth, which is a fairly standard version of a something that the nurses in A&E share with the local primary care optometrists to say, this is how we do our triage, this is what we need to see in 24 hours in A&E, this is an urgent clinic, this is routine, please all follow it. So again, hopefully lots of stuff that you can just take and use from other people. Have the next slide, please. And again, a similar sort of thing. So this is some of the cataract how-to. So everyone's going, oh, we need a shared decision-making tool. And if you've got one, fantastic. But if you haven't, there's a national one that we've done with getting it right first time. So just a 3-page thing, 3 simple questions. In London, optometrists are quite happy to actually agree to use this without extra commissioning. That's not necessarily the case anywhere, but they did. But you can take it and use it. And then again, if you want to get some kind of standardized drop regime across your hospital, across your system, and you want a patient information leaflet, well, here's a beautiful one that Central Middlesex, Northwest London have done that you can either copy or adapt if you need one. So trying to make it really, really easy so you don't have to develop these from scratch. Have the next slide, please. In terms of sort of going forward now, sort of priorities for the upcoming month, well, I think one of the things which is clear is that we need more specific hands-on deck to work closely with people. If we're saying we're going to offer some support, it's got to be a bit more than me or Carrie McEwing turning up and saying, well, we all think you should do this, why don't you? The people they want to have people who can spend time with them, who are skilled in commissioning, workforce, contracting, whatever it is, you name it. So we're recruiting more people in terms of commissioners, people who can do workforce planning and modelling. We're recruiting a set of operational managers who've led or managed ophthalmology service, but who also are really good at service and quality improvement, who can help work with provider managers to sort of get some of this stuff done. So that'll be really important, expanding the team who can give the hands-on support in key areas that certainly I'm not going to know anything about. We ran a webinar the other day with the College and GERFT on high volume cataract, and we're planning to do at least one a month and plus some extra workshops. So the next 2 will be commissioning and medical retina in September. The regions have generally been really good about appointing their ophthalmology and in many cases optometry clinical leads and the project management for their eye care programs, and we are going to be starting a national eye care board at which all the regions meet together to challenge, to learn, to see what needs to be done nationally, and we're having the first meeting next week to start doing that. In terms of some of the transformation work, they've been running patients through a digital hub where multiple providers share one digital platform to exchange diagnostic information. So they're starting to put some patients through that as a pilot. And we're undertaking an awful lot of commissioning and finance projects. So looking at trying to model what is the cost effectiveness and what is indeed the affordability of doing things in the hospital versus doing things in a high volume community hub versus doing a lot of stuff with optometry versus hybrid. And then to try and pilot some of those to see, okay, that's modeling, what is the real life look of that, to try and look at all the options and see, what works best and what's the balance of sort of cost effectiveness of those, and looking at some specific tariffs around bilateral cataracts, whole pathway cataract costs that could be sort of allow a bit more flexibility. And then finally, trying to develop a system whereby we don't show nationally data just because we have it, because in ophthalmology it's never the right data. We don't know who's got glaucoma in outpatients, nothing's broken down, we don't care mainly about length of stay and readmissions. So really working to get the right data up on the model hospital system. We're revising the GERFT gateway metrics, and it's likely, just to warn any people who have to do this, we're probably going to have a subset of those as sentinel metrics, and some of that will initially need to be collected manually on a regular basis, but it will then allow us to get the right data. Have the next slide, please. Okay, so that's all from me, but I'm going to hand over to one of my colleagues now, Nav Palak, who's sort of fairly recently joined the team and is going to, she's had a foot in both camps, in both provider land and national land, and she's going to talk to you a bit about some of the sort of key details of actually getting this stuff done. So Nav, really welcome, and hand over to you. Thanks.
Thanks, Mel. Hi everyone. I just want to say thank you for joining, and I'm going to try and talk to you about how you can get senior support and execs to buy into the changes of your eye care service that it needs. Next slide, please. So I thought it'd be quite helpful to give you a bit of a background to how ophthalmology has become a part of my life, because I'm not a clinician, but so you can understand the reasonings of why Mel asked me to present to you guys today. So I've worked in the NHS for approximately 12 years, and I've worked through many different areas, from primary care, secondary care, regional, national, and also private providers. And my first interaction with ophthalmology was in 2013, when I was appointed as an ophthalmology manager at a local DGH. I was there for just over 2.5 years, and following that I went to work at a tertiary trust as a business development manager for their benchmarking system that trusts nationally purchased, drew their HES data and performance against other trusts, see if they were outliers or if they were exemplars in certain metrics such as readmissions, length of stay, a bit like model health system, but it went down to patient details as well. I then went to join my substantive role, which is as a GIRFT implementation manager within the Midlands. And that was looking at supporting providers with implementing their GIRFT local as well as the national recommendations that fell out of that. Currently, I have been seconded over to the National Eye Care Programme as a programme manager and working in recovery, which covers the pathways, but also supporting workforce for the time being. Next slide, please. Okay, so I'm going to be totally honest about this. My introduction to ophthalmology, I think I was really naive when I first walked into ophthalmology, thinking, oh, it's going to be like every other specialty. And I didn't really foresee the issues that I was about to encounter, from targets not being achieved, and then the growing demand and the even bigger impact that was having on capacity. There were missed follow-ups, and then there was the potential of the serious incidences that could bring. The long waits for patients to be seen seemed to be even more frustrating with the inappropriate referrals that were coming in, especially with those that you know could have been seen within the community. The delays that happened in clinic meant there were bottlenecks, and that had obviously knock-on effects with delays in theatres starting. So there was, you know, cancellations that was either due to lack of consent, missing patient notes, or it was due to the delay of starting and then people not being able to work over the time they were supposed to. And that therefore had another knock-on effect in trying to get patients back in within a certain time frame to get their surgery done. Another big issue that we found were the number of the DNAs that we had. Was that due to, you know, them not having the information in a timely manner? Was it a language barrier? What was it? And then obviously when they did DNA, that led to the wasted appointment slots as well. So that could have gone to somebody who was waiting for a long time, but obviously it just gone. So one of the things there that made me look at was the interpretation policies, and they needed to be refreshed as well because they weren't suitable for the current form that they were in. There are also gaps, and you probably all had this as well, in staffing from nursing to consultants and medical secretaries. The service I would say needed investment. It didn't just need a dedicated manager, it needed actually time. You didn't need to do the day-to-day running because you'd just be ticking over. It needed a whole, lot of help and support. Of course, with everything I've just mentioned, what came from that, we had complaints. They were made via patients actually attending clinic, and they were legitimate complaints. Some were out of frustration for waiting so long. We also had some really, really lovely feedback. It wasn't all negative, and patients were really, really grateful when they were seen anyway. But some of them went through PALS, and some of them unfortunately did escalate to board level. At one point, I'll be honest, I did feel with ophthalmology, I was set up to fail in the first instance. But like they talk about ophthalmology in recovery now, but I think we'll all agree ophthalmology has been in recovery prior to COVID, and we've all just been existing. And actually, as a group now, we've actually got the airplay we needed for a very, very long time. Okay, next slide, please. Okay, so when I got there, I realised very quickly I needed to understand the history. What is it that wasn't working? So within the team I worked with, there was various different sites of the hospital, and the main site ophthalmology had just moved to. They were on another site originally. And I thought, is this a cultural work issue? Is it tradition that they've always worked a certain way? For example, when you join a new job and you've got some really great ideas and you go to a team and say, oh, what about this? If you consider doing this, and you get shut down straight away, and someone will say, well, no, we've always done things this way. Was it that, or was it because suggestions just weren't made? That wasn't the way they worked. I very quickly needed to break down the silos, because there was this thing about, consultants versus nurses versus management. That couldn't carry on. We needed to work together cohesively, because we needed to look after the patients and make sure our service was right. For that, it was very difficult, but I did need to build their trust. And rather than management doing stuff to them, I worked with them. I worked with all the team, whether it was clinicians or admin staff, just to understand what I could do to, make their job and role more efficient, and what their current issues were, what was holding them back. Some of them, it was like, what's the elephant in the room? It was trying to facilitate that issue. I then did a very, very time-consuming but essential audit of the service, and started to bring people together to discuss the findings. That was really good, because they could see their frustrations were actually being noted by management as well. I realised that actually investing the time within the department was really key to driving things forward. Next slide, please. Thank you. So what did we do? In essence, we had to do a service review of the department, as well as the daily operational side of it. There was obviously the business case was created that had various things in, such as recruitment, equipment, and other aspects like that. But some of the major things we did were introduce partial booking, and that was to ensure that we were aware of all the patients that the clinics aware of all the patients that the clinics were booked within the least amount of time of the risk them being cancelled. For example, as a consultant or a clinician, you can only book your leave within 6 weeks. So there was less chance of that being cancelled, because traditionally that was an issue as well. I also did a large piece of work, and this probably supports a lot of the stuff that Mel said about with consultants about RAG rating conditions with subspecialties. I didn't have anything to start with. It was literally a brand new piece of work. It took a lot of work with them just to go through what they thought, for a condition would be an urgent red, who would be amber, who would be green, and then actually when would they move up? When would a green patient clinically need to be seen as an amber patient because they haven't had a follow-up? And that was a big, big piece of work. The other thing what that allowed us to do as well was to review all the letters that had already been written from the initial appointment, and then rag rate the patients accordingly onto our pass system, so we could book them into for their follow-ups in the time appropriate manner as well. The other thing we did was, because communication wasn't really great within the team, and sometimes things that could have been discussed in the mornings were only flagged in the afternoon, for example, we introduced daily huddles so that nurses were always there, but we did invite consultants if they had time to come. But it was just looking at the, you know, any foreseen issues of problems that might occur that day, such as sickness, cancellation, equipment issues. The other thing the audit really highlighted, and it was very helpful to see why some of the bottlenecks were happening. So, for example, you had similar types of clinics running on the same day, but equipment-wise, there was a huge queue for the OCT, for example, and it wasn't the right thing to have them running side by side. So what that led to was changing the clinic templates. And then we also realised, actually, to look at our capacity and deal with this effectively, it's probably going to be a positive thing to start creating 3 session days, and that's what we went and did. And I'm not going to beat about the bush. It wasn't an easy process. There was a lot of resistance in the first place, just because it was something new. It was, you know, not many people did have evening clinics. But we did the whole consultation with nurses as well, and eventually everyone embraced it. So these clinics ran, we trialled a Monday, and just to see how it would go, and then from there we went for a Tuesday, Wednesday and Thursday. We didn't do Fridays because Friday evenings no one's going to come, they're going to want to enjoy their weekends. So the other thing we did do with the clinics is we targeted the working population, because there was a few reasons around it, but essentially it was about, a lot of the DNAs were from that cohort, and we thought it was probably around work commitments. So we targeted them to come there. We didn't book children in because when it's the evening, and especially if they're very young, you've got the issues of parents trying to get them dinner and try and get them into bed. And same with the ambulance patients. If we knew they were an ambulance patient, we didn't book them in, because ambulance transport only operated within a certain time, so we didn't want to, you know, cause other strain to the patients and stress. What the evening clinics did was eventually we increased our theatre sessions as well. So not on every day, but some days we went from the afternoon, we went right to 8 o'clock. And actually for some of the cases, for the complex cases, it worked really, really well. And on the end, we were able to do some more of the simple cases as well. And rather than asking for staff to stay over, they already knew they were going to be committed to a certain amount of time. So that worked well as well. Obviously, now we've sorted out our, you know, almost sorted out how the process of how we're going to manage our follow-ups and our theatre lists. There's the added issue of the backlog of the new patients. So the ASI list was growing, and I worked with clinicians to see how we could implement a new only clinic template. So how many patients they felt would be reasonable to see, and the time slots they would need in between each of the appointments as well. So that was agreed, and that's something that we worked on. The other thing in terms of nursing was we had nurses that did post-op cataracts, but actually there wasn't much else that they were upskilling in. So we looked at other courses they could do and other training. So I worked with Neighbouring Trust that had nurse injectors, because that's something that nurses said that they were really, really keen on doing. It was about making sure we had the right facility, and then also they were trained up to do so. So that's something that we worked on. The other issue that we had was the recruitment that I mentioned earlier, but that was a trust-wide issue as well. What happened was there was a huge recruitment drive for nurses abroad, and we asked to be involved in that, and we very much, you know, we were very, very lucky. We got a few band 5 nurses out of that, and who were trained up in ophthalmology, and I believe some are still there now, which is always great, because the worry is sometimes you train them up and then they move on, but no, they have retained their roles, I believe. One of the big impacts that I think that we really did do was the A&E clinic. I found that really difficult when I first started, because in a way nobody really wanted to take ownership of it. It was like, oh, I'm not A&E consultant today. But actually we then, you know, we came to a decision, we need some ownership. So we appointed a eye casualty nurse lead, and she was in charge of the whole process of the referrals that were coming in and making sure they were followed correctly by triaging the referrals. There was always a doctor that we had in A&E that was rotated in AM and PM. Out of hours, they went to the main trust within the Midlands, and then we also had a named consultant on the day as well, on call on the day, on the rota. And if that consultant, for example, was going to take leave, we'd already agreed whoever else was going to cover in. So, for example, if Dr. A is off, Dr. B is going to cover, and that was already arranged prior to, so we didn't have any issues later on. Next slide, please. Okay, so what's different now? So I think for me, as an ophthalmology manager, the buy-in that I so desperately wanted, and I had to really work hard to get. I mean, it's easy for somebody to say, look, I need you to get these targets, but you need the resource there, you need the support and the infrastructure. And I really had to fight the case. And it's a double-edged sword, because you've got, you know, clinicians, nurses, and on one side saying, look, I need this, this, and this, but then you need the buy-in from the execs. I had to do all that piece of work that was very time consuming, as well as my daily ops role. But I feel now actually we've got that buy-in, and it is, you know, it stems right from national to regional to the systems, right down to the provider. The message is out there that ophthalmology needs investment. Also, like Mel said, we're so joined up with other programs now, with you know, the outpatient program, GIRFT, high volume, low complexity, and, you know, the national eye care. And we do work together, we meet regularly, we discuss where we are with stuff. The message is the same that goes out, you know, and we're sharing that information. And like I say, the inappropriate referrals, we're covering not now just hospital providers, we're broaching that out. It's pre-hospital and post-hospital, what needs to be seen in, you know, hospital, and what can be seen outside as well. And that is, I think that's going to help resource hugely. Mel has, you know, done a great job, and she's gone over our support offer, which you know, it's something I would have absolutely jumped at and grabbed with both hands if I had had the opportunity to do so. The eye care hub is somewhere that we really want people not to just use for information. Yeah, of course, please use it for information. That's the first port of call, but use it as a discussion forum, get some ideas on there. You know, we really want that to be a real community of practice. We want that to be everyone's go-to, because there's going to be such rich data on there. I think it's really important that we do that. Next slide, please. Thank you. So from the support offer, I tried to think about it and say, what is there in that I would have used as an ops manager? And there's loads of stuff, but quite simply, I think the really, like, if I go to the stuff that took me loads and loads of time, it would probably be the RAG rating stuff that I had to do with patients. So the risk stratification document would have been a great tool for me to use, as well as any case studies that would have helped me, and, you know, to start those crucial, difficult conversations. It would have given me something to go to the clinicians with and say, look, all the work's done. You just need to adapt this to your, you know, local needs and what you think is clinically appropriate. The other thing that I think is an absolutely brilliant tool is the baseline assessment toolkit. That would have helped me massively with the whole audit that I did, it was it would have allowed me to have a really quick view of the service in a meaningful way. Where are the gaps? This is what they're saying we should have, these are all the tick boxes that, have you got your fail safe, have you got your ECLO, for example? And if that's what we should be having, and knowing, and saying, actually, that's what we've got, and this is what we need, it's very easy then for me to use that as a resource and go to the execs and say, look, you're asking for all of this, but we need all of this infrastructure first. Next slide, please. Thank you. So really, in conclusion, I would say, like, for years now, for so many departments, I think that, we've needed the support. And now that we've got the support, I think we need to use this opportunity to help improve the services as best as we can. Let's not waste it. And I'm sure most people won't, but if you can use it and to benefit, please do. Thank you.
Excellent. Thanks very much. And we'll probably move fairly swiftly on. Path must just pick up one question in the chat, which was around, I'm just having a look, it was Dan, wasn't it, from Norfolk, just around the whole electronic referral system. So I think as they stand at the moment, I don't think that anyone is proposing that there's going to be the end of this electronic eye thing. We're going to go, well, opera's clearly the best and we're all going to have that. That is not, I mean, you never know what's going to happen, do you? But that is not on the cards at the moment. And I think part of the reason why the NHSX, who really led this, was to, instead of going, let's choose one, they tried to develop one nationally for 2 years that would do everything, and they just couldn't get it right. And actually, commercially, there were quite a lot of suppliers, including ones that didn't do ophthalmology but had the functionality, who might be able to do it. I think the view was, it's better to have a bit of competition because it drives innovation up and it drives cost down. And I suspect the way to go will be much more about interoperability and making sure that whatever you procure can talk to everything and can fulfill certain standards, rather than saying Opera or Evolution or any of the F-Star, well, we're just going to purchase this forever nationally. And I think, the other thing to bear in mind is if you go for one commercial system nationally, then I think bluntly they're going to have you over a barrel. You really have a single point of failure, and it's very, very difficult to hold commercial people to account for a whole national system. So I hope that answers the question, but I'm going to move us swiftly on, because actually it's partly because I'm going on too long that we've been behind. So I'm going to move straight on to Tom and Manju from Frimley. So I'm really grateful for them both joining us, and I believe that Tom may have literally dashed at breakneck speed out of theatre, I think, to join this. Over to you, Manju and Tom, just to really hear about what you've been doing in terms of keeping things going, recovering after COVID, and then moving to transformation. Thanks.
Okay. Hi, my name is Manju Chandran, and I'm one of the consultants working at Frimley Park Hospital with special interest in medical retina. And I'm going to give you a brief overview how we recovered after COVID struck us. And I will be giving a brief overview about cataract and medical retina. And my colleague, Mr. Tom Kersey, will be talking about the glaucoma recovery plan. Regarding cataract surgery at Frimley, we always have done high volume cataract surgery lists before COVID for the past few years. But after COVID, we had stopped doing them. But for the last few months, we have started all our lists back to normal levels now. And we are doing 10 cases on a standard list and 8 cases on a training list. And it is going well. We have even tried out 12 cases on a sort of a standard list, but it is acceptable only to certain people, a certain amount of staff. You need the right team to do 12 cases. The other major changes regarding cataract surgeries, one I have to talk about is one-stop cataract pre-assessment clinics. It is, in the early days, it was very difficult because the conversion rate from the optom referral was around between 70 to 80%. But later on, we did some optom teaching sessions, and the latest results show that they have come up to 90% of conversion. Without a 90% of conversion rate referral from the optom, it is not appropriate to do a one-stop assessment clinics. We are also planning to split that part into slightly into two parts. Maybe one part may be for a telephone pre-assessment, and then patients come on the day for the pre-assessment clinic, including the consenting. So that's one thing we have done. And second part, for a high volume, low complexity list to really succeed, we need to do bilateral surgeries. We have been doing bilateral surgeries for some time now, but when we looked at the group of people we had, only 50% of the patients were receptive to this bilateral surgeries, and also it differs from one consultant to other. However, I have to say that if you have 3 bilateral surgeries on your high volume list for 10 cases, it definitely saves time. Whenever we have done a high volume list, I have felt is that the surgeon is not the most important part of the member of the team. It is the people around you. If your turnaround time, you don't need to be a fast surgeon to do a high volume list. You can take good 10, 12 to 15 minutes, but if the turnaround around you is happening quickly and the patient goes in and out within 5 minutes, it is possible. It is not a big ask at all. The moment we say high volume, surgeons becomes a bit worried, saying that are we thinking about all the safety options? Are we compromising anything? But actually it is not. I will say it is the right team you need to do that. But without the right team, sometimes it might not be possible. And picking out your cases is also slightly difficult. It might not be sometimes when you get 10 cases, it might not be all straightforward sometimes. But with over a period of time, I think it is a possible option. The other thing for a high volume list to be successful is that you have to practice home dilation. Home dilation we have been doing at Frimley for ages, but recently we have streamlined the whole pathway with proper PGDs in place, and we have the pharmacy support, and pharmacy gives the drops as pre-labeled boxes, color-coded boxes for the patients to use. And finally, for after all the work being done, capturing the data on Medisoft, the refractive outcome on Medisoft was again a huge problem for us. We are still working on it. Our trust is going to be completely on electronic patient records by early next year. So we are planning to get in touch with all the optoms and secure them also in this network so that they can upload the refractive outcome electronically. Currently, we have a posting system or the patients sending it back. And I have to tell our numbers are around between 75 to 80%. It's not great. So that's about cataract surgery update. And I have to talk to you also about medical retina. Regarding the medical retina recovery, macular degeneration patients have never been a problem for us because all of us have seen AMD patients during the pandemic. And for us, it was much more easier because we have a mobile macular unit which goes into the community to see patients. It goes to 4 different locations and we see around 250 patients every week. Since it can be considered as a part of the green pathway, that AMD patients were never a problem for us. The only problem was for the diabetic patients during this difficult time. What we did was that the whole group of diabetic patients, we have converted around between 80 to 90% of them to virtual clinics and run virtual clinics 10 sessions a week. On the back of the diabetic virtual clinics, we also have tagged along hydroxychloroquine pathway and a stable macular clinic for patients who attend the other VEGF clinics. So these are the major changes that has happened in the medical retina. Otherwise, medical retina, we did not have a major problem. The only problem which we had later on, we found is that we did not have a fail-safe officer for the macular degeneration patients. Since we looked at all the data that has captured during the pandemic times, and we are in the process of appointing a full-time fail-safe officer which can look at medical retina, glaucoma, and one day we have assigned for cataract also. So that is from me about the cataracts and medical retina, and Tom is going to talk about the glaucoma recovery plan in detail.
Hello, and thank you very much for having me. Hopefully this is going to be of some use to you. I'm going to talk about the glaucoma service at Frimley, building back really after the pandemic. So can I have the next slide, please? So the pandemic was obviously a tragic thing, and it is an ongoing problem. There's a lot of uncertainty around it. But I think it has also brought a possibility for huge opportunity and changes within units and within the models for glaucoma that we currently use. Can I have the next slide, please? So I think it's fair to say across the UK, there are lots of different models of glaucoma care. We have shared care pathways, which are run by optometrists in the community. We have hospital-based traditional doctor-led services. We've got allied health professionals working within those services, be they optometrists or orthoptists. And then there's a great number of different private providers like New Medica, for one example, who are also running glaucoma services within the community using a variety of different models. Can I have the next slide, please? The basic challenge we feel in glaucoma is essentially identifying those cases that are progressing. Those are the ones that we want to try and find. Those are the needles in the haystack. And the only way to do that is by collecting data, and we need good, robust, reliable ways of assessing that data, gathering the data, assessing it, and then feeding it into a system where we can risk stratify it. Glaucoma patients undoubtedly make up a large percentage of eye unit case numbers. And I'm really talking about not just glaucoma cases, but ocular hypertensives, your glaucoma suspects, your narrow angle patients. But when you look at all of them, you've realized quite rapidly that you've got a high risk and a low risk pool. There's a lot of patients in the low risk pool who do need ongoing assessment, ongoing review. And then there's a much smaller number of high risk patients, and they need diverting into doctor-led clinics to manage their surgery and their medical side of treatment. Managing flow in and out of a glaucoma surface is also really, really important. If you're not careful, you end up with an increasingly large stagnant pool of patients. And I think it's really, really important for those low-risk patients to be identified and discharged back into the community, and to allow new patients to easily flow in. For a long time, we've concentrated very hard on putting barriers up to referrals, stating certain levels of pressure, but actually, in some ways, what you need to do is have a very rapid and fully encompassing new patient clinic that can assess the patient fully and then make a proper decision on them. And that way, you're not going to accidentally put the patients into the wrong area or not allow them into the system. Can I have the next slide, please? And the next slide, please. So COVID created lots of chaos everywhere, up and down the country. One of the biggest problems it created was that there were large percentages of patients who were being unseen, partly because of low flow rates through the clinics. We were having very low clinic numbers. A large proportion of the patients are elderly, and we're avoiding coming to hospitals or gathering. The optometry services in the community were also cancelled and not functioning properly. So there's a huge paucity of data available for these patients. Our carefully managed glaucoma service at Frimley Park, which consists of a doctor-led high-risk clinic and a much larger allied health professional-run low-risk clinic, that all became very disrupted, and patients were in different pools. There's also been an uncoupling of the hospital and community systems because the optometry services haven't been running properly. Next slide, please. So we took very much a team-based approach at Frimley by gathering everybody together to have a glaucoma strategy meeting. So this is not something, fortunately, that's new to us. It's something we've been doing for many years. And we always gather the key players, and that includes the consultants, the managers, and the allied health professionals who work within the team. We've spent a lot of time listening to each other, coming up with ideas. I try not to be too prescriptive, but instead ask for their ideas, because they've got a great idea about pinch points, strategies on ways to improve efficiency. Next slide, please. So I think Steve Jobs put it really well when he said that basically there's no point in being top down. There's no point in having all these experts of allied health professionals who work within the team, who do the job daily. They're the ones that see where the pinch points are, whether you've got too many patients in OCT and you need to change your pathway a little bit. But essentially creating the pathways to allow a smooth flow of patients through helps with footfall through the clinics, so it avoids patient delays, and that in turn leads to far less complaints. Patients are very happy, they have a very efficient pathway through. Next slide, please. So we felt during the pandemic and you know, as we did before, really, there are three key strategies to getting out of this pandemic quickly, and one of them is to gather as much data on as many patients in a shorter period of time as possible. So we switched all our doctor clinics virtually, apart from 4 consultant-led clinics a week, to virtual diagnostic clinics. So we gathered in our allied health professionals, we utilised all the visual field and OCT machine slots that we could, and we ran designated glaucoma diagnostic clinics. Patients would come through, they'd simply have their investigations done, and they would go back out to the community. 1 week later, they would have their results read by a doctor and a decision made. And that way we were gathering large amounts of data and doing very high volumes of patients a week, much higher than we were ever able to achieve through doctor-led clinics. We rapidly re-established our risk stratified pools. So as soon as we could get the glaucoma unit, the allied health professional led glaucoma unit running again, that's our low risk pool, we were able to phase our patients back into that and then identify the high risk patients and drive them through the consultant clinics. We wanted to keep the new patients flowing, so we used high volume new patient clinics, which I'll discuss a bit more in a moment. Can I have the next slide, please? So it's just all about getting data. We wanted to try and create as much data on as many patients as possible, because that was the only way we were going to be able to work out which level of risk that each patient had, and then we were able to risk stratify them and get them back into the right pools. Next slide, please. The other thing, just talking about risk stratified pools, we did feel that it was worth limiting people's options on follow-up slots. So for the high risk clinics at Frimley, obviously the post-op patients and those high risk patients, they'll be seen as a needed. But for those other patients with perhaps post-op tube patients, post-op trab patients, we would keep them on 4 and 6 month reviews as options. And where we're talking about patients in our low risk allied health professional pool, we just give them the option of 6, 12 or 18 months. When they've got 2 clinic or 3 clinic reviews in a row which show stability, they get pushed down the rung. So we try and push as many patients from 6 to 12 and from 12 to 18, as long as we've got the data there to support it. Next slide, please. The glaucoma assessment clinics are our high volume new patient clinics. We've gathered 3 allied health professionals per consultant, and we run these clinics 3 times a week. Each allied health professional will see 8 patients, and they will do a full workup. So all the patients will have a visual field, IOP, CCT, they'll have their Goldman assessment, and the allied health professional will work the patient up completely, and they will discuss each case with the consultants. And we find that by doing this, we're able to get through between 24 and 30 new patients per clinic, and that gets us up to around 80 to 90 patients per week, which has rapidly reduced the backlog of patients, and it allows for a very, very rapid diagnosis, consultant delivered with efficient signposting to get the patients into the right place, and also to efficiently discharge those patients with a full data set. So if they do come back in the future, we have got a full baseline data set on them. Next patient, please. Next slide, please. Sorry. So new lessons learnt. Really, we felt that it's kind of important to think about designing services and responsibilities. We've decided at Frimley that we're going to really try and keep all of our care underneath the hospital. We will continue to expand our stable glaucoma clinics, and we've already in the process of doubling that by offering another community hospital site where we're going to run another glaucoma unit. A fail-safe officer is hugely important in glaucoma, as it is in medical retina, to try and stop patients falling between gaps. And this is where one of the things that worries about us about having multiple providers and too much community shared care work is that where does the responsibility lie? And we must not allow patients to fall between to gaps, because we run a risk of losing patients to follow up, and unfortunately they may lose vision. So risk stratifying patients, managing the patients efficiently on efficient pathways, and really listening to our allied health professionals has been a huge help in managing very high volumes. And we're now looking to get things back to a more normal setup over the next 3 or 4 months. Next slide, please. So I think although COVID has been, you know, an unmitigated disaster in many ways, I think it has focused minds on how the services are delivered, and really about what is key importance in glaucoma. And a lot of that is about having enough data to be able to make a rapid and safe decision on patients and to guide their pathways. So that's all I've got to say on glaucoma. I hope that's been helpful. If I can answer any questions, I'll be very happy to.
Brilliant. That was great. Absolutely fantastic. I really love the democracy at the beginning. You know, the democratic process. That was fantastic for you, both of you. I've got about 1,000 questions actually, but I'll just ask anyone else who wants to, please do put your hand up. I think one question for me is about how much of this that you've described is temporary because of COVID delays, and how much of these changes are for life?
I think a lot of the pathways are for life, Mel. So we'll go back to running our high-risk doctor clinics, and we'll run our allied health professional low-risk pools. And I think that's our way of maintaining good stability. But there's no doubt about it that running the diagnostic clinics, even on a temporary 3, 4 or 6 month basis, is one very, very easy way of getting rid of the backlogs, but creating lots and lots of data on the patients. And I'd certainly look to utilise it again if the management team come and tell me that we're running behind on follow-ups. That would be my first step, would be to, well, actually, we've done this before. It's very easy to get back on top of everything. We just need to run diagnostic clinics at high volumes for a short period of time to restabilise everything. And
do you how do you, I'm interested because I'm thinking about, you know, I know quite a lot about kind of what Moorfields did on this, and a lot of the sort of changes were about trying to find the correct, the layout, if you like. They do these kind of lanes thing. Is that, did you have to change the layout of the clinic, or were you able to? And does that lead to a kind of, well, we're going to do a community hub, and is that what you talk about in the community hospital? I think that was one thing. I wouldn't mind also just knowing very specifically around how you do the whole drop compliance support, you know, here's how to put a drop in stuff, you know, the support stuff for the kind of high volume virtuals.
Yeah, so the pathways were already established, fortunately. So we already had, I loved Manju's mobile macular unit, and about 5 years ago, when I wanted to set up a much higher volume glaucoma service, that was the model, using Numedica as a, you know, unshamefully copying them as a system for creating a pathway for the patients. So we actually couldn't afford to use a mobile system for the glaucoma system. So we used 2 rooms out in a community hospital. One is an investigations room where the patients come through having a visual field and an OCT and a vision. And the next room is along is the allied health professional who finishes off the assessment. And the diagnostic clinics just ran through the same pathways, obviously minus the allied health professional. We were able to use the rooms for doing virtual reviews. So we were able to utilise our doctors to do the virtual reviews. You mentioned, sorry, Mel, what was your second point? I've forgotten it.
I think it was just about the whole kind of drop support thing.
Yeah, so drop wise, we have compliance clinics at Frimley. So just try and stop short trawl through the doctor clinics. We set up nurse-led compliance clinics 5 or 6 years ago, and all patients who started on new treatments, be they virtually or be it in the doctor clinics, will go at 6 weeks to a compliance clinic where they'll have their drop placement assessed. They'll be asked how they're getting on, and the doctor or whoever started them on the drops will have to have already stated a target pressure and a planned follow-up. So as long as they're meeting their target pressure and they're actually applying their drops properly, then they can go back into the pool, either into the stable pool or the unstable pool if they're not meeting their target. But there's also a talk in that clinic from the nurses about compliance aids, which I think are hugely helpful.
Okay, so basically you've managed to feed this into the whole, because I think that's one of the things that people get a bit worried about, that it's going to be, it's going to be such a factory, a conveyor belt, that people aren't going to get that. And I think there seem to be a number of different ways of doing it, but it shows that you can. There's a couple of questions in a minute I'll pick up on the cataract from Natasha, but I'm going to just stick with glaucoma from now. So there was Ariba's asking one around this is, I know people are scratching their head on this, the whole gonioscopy thing, both for news and then ongoing virtuals. And I know that, again, I'm not a glaucomatologist. I know there are people that introduce anterior segment OCT, and I know there's arguments about that. So what about all the kind of, narrow angle people? How do you handle that, Tom?
So we push all of our patients, narrow angles and ocular hypertensive, etc., glaucoma suspects, through the glaucoma assessment clinic. So that's the one with 24 to 30 patients per clinic, and they will all have a Van Herrick grade. They will also then get a gonioscopy by the consultant. So the consultant doesn't have his own big list. He'll have a small number. So I do a few post-ops, maybe 3 or 4 post-ops during the morning. But my job is essentially to run around between the 3 rooms that the allied health professionals are using, gonioing them, looking at their disc, having a quick chat, moving on to the next one. And so long as you can keep moving, it's very efficient. Gonioscopy in the stable pool is a more tricky option. So generally what happens is that the doctor-led clinics tend to hang on to the narrow angle, the chronic narrow angle patients, and the stable pool is your ocular hypertensives with open angles. But it is something that we thought about, and one way to do it would be to every 2 years or 3 years make sure that all of those patients in the stable pool come through the doctor clinic once every 2 years, and then they circulate back round, and that would be the way probably to do it in the future.
So it's a bit of sort of safety check. In terms of and this is actually a question for both you and Manju, actually, potentially. So obviously you're both using, or in MR and glaucoma, using a lot of virtual clinics. What are you doing in terms of, avoiding just the medical burden of decision making? So how much are you both using the multidisciplinary team for clinical decision makers, and how have you upskilled them, etc.? Because I'm working on the assumption that no one consultant wants just to be a reader of clinical data for the rest of their lives.
Yeah, I think that's a really good point, actually. Personally, I find 1, possibly 2 virtual clinics a week is plenty. Any more than that, and you do get very mind-numbed just flicking through the data endlessly. And there's only so many cups of tea you can go and get. I think it's important to, again, risk stratify it. And you could train allied health professionals to screen in the same way that you sort of run a diabetic screening service on primary and secondary screeners. And that's probably the way, if we wanted to get through very large volumes going forward, that I would do it in glaucoma. But for us in glaucoma, what I've done here is go back to our old model, where I've got the allied health professionals seeing the patients directly, the doctor seeing the patients directly, and we'll keep the diagnostic clinics for the times when it gets too busy, and then we'll bring them in temporarily. But I think if we introduce them permanently, it would be burdensome, and we'd have to think then about training in a tiered way. Have you got any thoughts on it, Manju?
For our diabetic patients, all the images are graded by middle grade doctors. Initially, I used to give them in-house training for them, but recently I'm also the clinical lead for the Surrey diabetic screening program. So there's an EQA test online for the graders in these diabetic screening programs. So I'm making all the middle grade doctors do the test at least once in 2 months. Otherwise, when you give them 20 notes to grade, like Tom said, it becomes monotonous and there is no safety net mechanism for us here to check it. So we are actually making them do the tests online.
Great, thanks. I mean, I noticed that so Molly also from Norfolk has just said you've got I don't know whether or not you fancy unmuting and telling us more, Molly, about you've got nurse protocol to review the new patients. Do you want to, if you don't mind, do you want to tell us a bit about that?
Actually, Rachel here. We're sharing a screen.
Cool.
Hi. So we have these rapid access glaucoma clinics where we do a vision, a vision, an IOP, and RNFL OCT. And then the nurses have a protocol, so they review. So we see 20 in a clinic, so 1 visioner, 1 nurse, 1 photographer. And the nurse doesn't have to be a specialist nurse. So they get through 20 patients in a session. And then afterwards, the specialist nurses have a protocol where they review. So it's not all the burden of the consultants. And they can then assess when the patient needs to come back or what they need to have after that.
Brilliant. And out of interest, how many what sort of proportion are you able to discharge from that?
Oh, I'd have to ask my glaucoma colleague, but I think probably about a third, but I'm not sure.
Yeah.
And we also have a new one now, which is a rapid anterior angle assessment, and that's doctor-led. But again, it's pretty quick flow through, and they do gonioscopy, I think, don't they?
Yeah, must do. Yeah.
But they don't do the PI at the same time, obviously. But that's well, we have
pushing it.
ones where they do
Yeah.
that.
Come, have your PI, discharge, never see you again. That's phase 2 of the transformation. So.
Yeah.
Oh, brilliant. Thanks for that. No, that's really helpful. I mean, I'm interested because there's obviously lots of different ways of employing this. I mean, so in Moorfields, they've gone for the new patients again, all because we don't have any primary care optometry in North Central London. So they're all seen through a virtual clinic, technician led, and then review and consultant review and discharged rather than seeing them. But I think there's lots of different ways to skin a cat. Out of interest, Tom and Manju, how much, I know you mentioned about post-op cataracts, and it sounds like that's a challenge. Do you have much in the way of primary care optometry input into any of these pathways, or are you planning it?
Currently, we just have a telephone post-op follow-up for these patients, but we are in the process of rectifying it to completely discharge the patients to the community, but there is a tariff associated with it. So the trust is not quite on board with it, but we have to make further negotiations to sort it.
Brilliant, thank you. All right, and so thank you very much to both of you, appreciate it. I'm just going to pick up just one question from Natasha in the chat, because she asked a couple about the cataract. So Natasha, you were asking just firstly about post-op regime, about Nepanthenag. I don't know is the answer. It's an example of the central Middlesex. So I'm not sure how many people are using it off license. I think that the central Middlesex have a really a sort of quite a challenging population, a ton of diabetics, lots of different ethnicities. So I think that they tend to throw everything at their post-ops, or there's quite a lot of complex patients, hence the use of non-steroidals. And then just again, and it might be worth just sort of asking Manju briefly, yeah, in terms of the sort of the stuff coming out from GERFT about the blood pressure, etc. I mean, I would say, as when I was chair of professional standards at the college, which I've just finished doing, the single most frequent question either on the clinical leads forum or coming to the college was, does anyone have a protocol for blood pressure, INR, and diabetes for cataracts, because we keep cancelling these patients and it's just like a complete waste of time. So I think that, you know, the new sort of short guidance, which is either you can get from GERFT or it's on the Eye Care Hub, which is essentially the message is just sort everything out before the day of surgery and have a protocol written down so that everybody, including the anaesthetists, the nurses, the people on the ward, all know what you should and shouldn't do regarding blood pressure and diabetes. But basically, anything that might not be right has just got to be sorted out before the day of surgery, so that ideally when they come in, you don't really need to measure anything, whether it's blood pressure, you know, BM or INR, unless there's something very wrong or the patient's unwell, because actually there's really no great evidence base that any of it matters. As long as your INR is within the therapeutic range, which it really ought to be anyway for your health. This is phaco, you know, they're not going to bleed, and there's good evidence from the NOD, 55,000 patients analysed a few years ago, showing that your INR really doesn't matter for phaco in general. Again, blood pressure, if you measure it on the day, you're probably going to find it's high because they're stressed because of an operation. Measuring it on the day is not really, doesn't actually make any sense. So I think if people were able to follow that guidance, which has been passed through the GERFT anaesthetists as well, and highly experienced people who do a lot of cataract surgery, both surgeons and anaesthetists, I think we'd all save ourselves a lot of trouble. Manju, do you do any how do you handle the whole blood pressure, diabetes stuff for high volume cataract?
I think 2 years ago we stopped checking blood pressure, blood sugar, everything, because we used to check HbA1c before, and in HbA1c below 70, it was okay for cataract surgery. Anything above 70, we used to send it to the GP during the pre-assessment period. And we stopped checking blood pressure. And then one day, one of the patients had a cardiac arrest on the table, and we called the crash team. And the crash team asked, what are the first observations when you admitted the patients? So at that point, we landed in trouble.
Well, it's true, but I think that, you know, what you've got to do is like with all of these things, you know, did that make any difference to that patient? And do you have to introduce a lot of checks for the one-off thing that likely is never going to happen? And it's a balance. And I think for all of these things, you have to risk assess it and agree it and do what is the sensible. But yeah, I know you can't control for every availability. So thanks for that, Manju. We'll move swiftly on. So I'm going to bring everything to a close. I know I haven't answered every single question, but really, really grateful to Nav, Tom and Manju for speaking. I thought they were all absolutely outstanding talks, really, really excellent. And Tom, I'm afraid with the national team will almost certainly be coming to you to get a sort of little case study out of what you've done to sort of share with other people, because it was just great. We'll set up another one of these next month. People can feel free to let me know whether or not people prefer these short, sharp ones, whether the timing's right, whether you'd like to have go back to the odd one, which is more of a sort of 3-hour or even an all-day session. I think we'll do whatever members want, but really just thanking everyone for joining. Keep battling on, and as Nav says, this is a real opportunity. That, you know, there is money, it's just there's no new money, but we're at the top of the pecking order at the moment. So if you want something and you can show that it's going to benefit patients for ophthalmology and eye care, now is the time to ask. All right, so thanks very much, everyone. Have a great rest of the day. Bye.
Thank you.